Hi, my name is Dr. Brendan McCarthy. I am the Chief Medical Officer of Protea Medical Center in Tempe, Arizona. Welcome to my podcast. Today we are shooting from a new location with new angles. we we're moving the podcast over to the office. We moved our facility over the past year, and the new space is a little bit bigger, and we are setting up a podcast studio, like a little studio where we can film in. And I will bring the dogs in for that for sure. So I will have them in the future. Today we're just kind of making the transition over. So I think for a few episodes you may see me with this background. This is just one of our treatment rooms that we're using for today's episode. Like I say at the beginning of every episode we've done of this podcast, your voice is very important to me, and your input is important. It's what drives the podcast. A lot of your comments are the things that help us know what to make future episodes on. These topics are important. I can pick the things I know are important for what I see that come into my office, and I know those are good and those are helpful because I'm seeing that come through the office. But hearing it directly from you is actually even more important to me. So please, your comments mean a lot and keep them coming. To the degree that this podcast is helpful for you, please subscribe. And to the degree you think it'll be helpful for someone you know, please share it. And if you like what we've done in this episode, please like it. With that said, let's get into today's material. Following along the concept of what I just said with comments, today I'm going to address a lot of the comments that were done over this past month or so, almost a month now. We've been running a series of episodes on treating menopause. And a lot of the reels and the podcast itself got great response. I had a lot of feedback, a lot of good questions, and a lot of really valid feedback. I'm not going to say it was criticism. It felt more like I don't understand what you're saying here, and I'll get into that in a moment. That's actually be the first one I'm going to do. It's so tricky because we do this full episode and it'll be like a half hour, sometimes more, sometimes less. And there's a lot of material in there. And when we make these reels that get put onto Instagram, Facebook, and TikTok, wherever else they go, they tend to get clipped in a way that maybe it seems out of context and maybe confusing. And the first question I'm going to respond to is from one of those. And it's tricky because, as a man, saying, this is your identity. I know that was could be a trigger. And when the reel came out, I knew I was worried that I came across arrogant, and I worry about that. And that's the furthest thing from who I am. And I know you're just getting to know me through this podcast, and I know there's the concept of the person in front of you. It's not necessarily the person I am when I'm off camera. I am this person always, though. And I have patients who can probably attest to that in the comments section somewhere. I'm sure they will. But still, I don't want to say things that offend, because I think that gets in the way of the message I'm trying to share. So this one comment and is from Middle-Aged Goddess, and she wrote, and it is beautiful what she wrote, and it is important. My life as a woman is not over because I'm in menopause. In fact, I wish someone had told me how amazing it is not to be a menstruating woman. I'm not supplementing with any HRT and feel fabulous and more like myself than I ever have before. I'm so confused with what you're actually saying here, especially because you've never experienced it. Truth. I hope I do a good job right now giving you clarity on what I was trying to say. When it comes to hormone replacement therapy in a woman, when I wrote that one, it was based on the idea that some people believe that when you start hormones, you can never stop, that you become dependent on it, and that's it. So that whole episode was the idea that it's not something you become dependent on, but it is something that is going to shift your health in a certain direction. Now, say you're seeing me in clinic for the first time, and you are postmenopausal, and we run your labs. I want you to know when those labs come back, I'm very clear in communicating that I'm not going to sit here and advocate for you to do hormones. I don't do that. Instead, I sit down with you and say we find in yours bone density loss. So say I run your labs. Your alkaline phosphatase, which is one of the metabolic panels, one of the parts of your metabolic panel, is above 100. That is very suspicious for loss of bone density. And say we follow up with a DEXA scan showing there's loss of bone density. I could be that doctor that says, well, we're just going to do estrogen for this. That's not what I do. I let you know that that is an option. I would be a horrible doctor if I said that's the only option. So I'm saying your health is here when you're on that hormone and your health is here when you're not on it. Your life is here. It means that when you don't have estrogen in your body, estrogen fulfills an important role. It's a part of your identity in the sense that it physically plays a role in your physical identity, bone density, cholesterol, brain, memory, hair growth, all of these things it helps with. And when you have a pathology in your life associated with that estrogen being low, that's something we have to figure out how to fix. Now, you coming to my practice and saying, we have this difference here, we have this problem, you're losing bone density. When I sit down with you, I'll say, estrogen will work. If that's not an option for you, we could try testosterone also. So for some of my breast cancer survivors that I see that are estrogen receptor positive, we tell them, okay, we can't do estrogen in this case. Testosterone has been shown to build bone density, so we'll use testosterone in that case. If you want to be no hormones, I completely respect that because I'm not a hormone doctor. I'm your doctor. So then you and I put together a plan on how to build bone density. There's supplement protocols that work well, exercise routines that work very well. But I would be a bad doctor again if I put you on that protocol and say, well, take calcium. What kind of calcium? How much calcium? What else do I take with it to make the calcium work? We put together a protocol specific to you to help make sure that calcium is bioavailable and that you're absorbing it. And then we put together a lifestyle exercise routine that we go later on and remeasure. Did it work? When you come to me and you're having bone loss, I want to make sure I do my best job to get your bone density back up. And whatever I do to do that, whatever we choose to use together, I run that lab for alkaline phosphatase. I do the DEXA scan to verify what we're doing worked. So I see you. I see you. You're valid with your concern with that. I just hope you understand where I was going with that is that we just need to take care of you differently when we're not doing hormones. And if you're not doing the hormones and you're here, I need to be clever with talking about how to treat your cholesterol. I need to be clever when it comes to how can I maintain healthy hair, how you can work with memory. There are many tools that I can use. I just need to make sure I do my job sharing with you that since you're not using estrogen, these are the tools I have to use to get results for you. And then not just tell you that's how we're going to get results, but prove to you I get results. Thank you for your comment. Thank you so much. And feedback like yours is really important. And you are right. I'm not a woman. I will never be a woman. But that doesn't mean I don't care and I don't want to do a good job. And I'm in this space and I'm very thankful for being in this space with you and doing this work. So thank you. The next question is regarding progesterone. And she writes, can you please make an episode about having reactions to bioidentical progesterone? I have low progesterone, use cream in the last 14 days of my period, but every time I stop with the cream, I get anxiety, depression, my hands shake, and I feel terrible. What to do? I want to address this. There seems to be two things going on here. It sounds to me, and I hope I'm reading this correctly, but if it sounds to me that when you stop the progesterone, that you have these symptoms. I want you to know that those symptoms are not because you took the progesterone, it's because you stopped taking the progesterone. Progesterone, when it crosses the blood-brain barrier, it binds to GABA receptors. It turns to allopregnanolone. Allopregnanolone in the brain binds to GABA receptors, and it's a natural anxiolytic, or it reduces anxiety. The GABA receptors are also, when there's an issue around GABA, you'll see some tremor in people as well. So more often than not, what you're describing is someone who needs to be on progesterone, discontinues it for a period of time, and they have those symptoms. Now, this is a bit complex, so I'm going to kind of circle back and be really clear here. If you are a woman who's menstruating, you're still cycling, we know that progesterone should be high the second half of your cycle, which will be day 18 to day 28. That's a good time to use progesterone. Anytime after ovulating, progesterone should be on the rise and stay high. You still have progesterone in your body the first 12 days as well, just not as much. So sometimes with women, when we give them progesterone You give them for the last 2 weeks of their cycle or last 10 days, day 18 to day 20 of their cycle, very commonly. And then once they have their period, if they feel terrible, poor sleep, poor mood, anxiety, the things you describe, we will give them very low dose progesterone during the follicular phase, which is the first 2 weeks of a cycle. Now, that's one therapy we do that works and works well. That can be very helpful in your case. Um, if you are menopausal, postmenopausal, I want you to know that in my practice, I do not practice or use the concept of cycling progesterone in women who are postmenopausal. Once you cross into menopause, I maintain progesterone all month long with my patients. The benefit for sleep, for mood, for breast health, just overall, the benefit of progesterone, it's always there. So I prefer my patients staying on progesterone. I know there are those who believe in a cycling and having women menstruate even in when they're postmenopausal. I just am not one of those physicians. I don't do that. So I do progesterone all month long when you're postmenopausal. Now, there's one more thing that you may be pointing out here that I didn't read it correctly, so I want to answer this one too. Sometimes, rarely, but it does happen. Women, even with bioidentical progesterone, when I give it to them, they have anxiety attacks from taking progesterone. This does happen. There still is not enough research done about women. When you look at the literature and you look up progesterone intolerance, they often talk about synthetic progesterone intolerance, and they don't really differentiate with micronized progesterone, which is bioidentical, versus synthetic progesterone, which is medroxyprogesterone acetate, and all those synthetic variants of that. So when you read the literature, they just talk about synthetic progesterone. I want you to know that it also happens in bioidentical progesterone. Women who take bioidentical progesterone can rarely have that reaction. What we suspect it is, and there's still, again, not enough research. We need more research, but what we suspect is happening is that when progesterone crosses the blood-brain barrier, as I mentioned, it should be converted to allopregnenolone. With these women, instead, it's being converted to pregnenolone sulfate. Now, pregnenolone sulfate is a derivative, is a different type of progesterone, or a different type of pregnenolone, excuse me. And that one is more associated with creating anxiety. Pregnenolone sulfate is brilliant for memory and for learning, but not good for mood. So women who take bioidentical progesterone who have this issue, we have to work around that. There's several ways we try. Sometimes I'll do oral pregnenolone, which you think, well, Brennan, if you take pregnenolone, why didn't it turn to pregnenolone sulfate? Again, we need more research. But I can tell you when I treat those women who have anxiety and it's from low progesterone, and if I give them progesterone, it makes it worse. When I run a lab for their pregnenolone, I often see that pregnenolone very low. I'll start giving them pregnenolone at night before bed, 30 milligrams to 60 milligrams. I rerun the labs within a month. Our goal is to bring it up close to 100, 150 even. That has worked in the past for me. Other ways that could be try and be beneficial, testosterone. I know it's an androgen, but in low doses, when it crosses the blood-brain barrier, androstenediol, that has an impact on in the amygdala. It's an anti-anxiety agent as well. It can be helpful. It's not perfect, but it plays a role. So long as I'm using a level that's consistent with women. There's a level for men. There's a level for women. And so as long as I'm keeping it there, we should be very safe. But again, we watch for testing for downstream metabolites that may cause side effects. That's a long answer. But I hope it answered your question one way or the other, or both ways. But if it didn't, circle back. Let me know. Please comment. I do read your comments. As you can see, I'm going through these comments today. We're making some episodes about this. So thank you for this comment, and I hope this helped. The next one caused my blood pressure to pop just a little bit up, just a little bit. I can't be everyone's doctor, and it'd be crazy to try and pretend I could be. And I want you to know I'm in this space with you um, to do my best to give you information so that way you feel empowered to ask for what's right and for what you deserve. This is a big one for me about to read. And this comes from AZ Classy One. And she writes, my doctor says that since I'm 69, I no longer need progesterone. So I was weaned off of it. Since then, I have gained weight and my body aches. Is this a direct effect of not being on the progesterone? I have my yearly appointment coming up. Should I ask to go back on the drug? Yes. So I would say first, it's worth considering a different physician. It's a different physician. Um, since you're 69, you no longer need progesterone. You are more than the sum of your uterus, is a saying I like to use because it's a truth. You Progesterone is a part of your biology that has been there since the beginning at higher levels than men have. And your brain chemistry and your physiological chemistry was made to have it. Part of aging is this mild endocrine failure that we go through. And sometimes it goes faster for some of us, and sometimes it goes slower. Nonetheless, you see a diminishing return on all these hormones. There are consequences for these hormones becoming lower. These consequences really do negatively impact our lives, our health, our wellness, our overall wellness, and they're very preventable in a safe way, progesterone being one of them. Male doctors and female doctors, but mostly male doctors, really see this through a poor lens, in my opinion. They think that if you don't have a uterus, you don't need progesterone. Your breasts respond to progesterone, and progesterone is a very protective compound, against estrogen stimulation. So as estrogen stimulates growth, progesterone inhibits that growth. Same with the line of the uterus. Um, with body weight, yes, that is true. There's an estrogen progesterone ratio, that when it's off and you don't have any progesterone, you just have estrogen, your body fat is being stimulated, and that adipose stimulation can cause this, where you feel like your weight is going up. And so when we bring progesterone back up, that helps shift that in a positive direction. There's a solid amount of research explaining how progesterone in balance with estrogen helps with weight. Big. Um, when it comes to seeing my patients, I don't see them yearly. I see them every 6 months. The American Academy of Clinical Endocrinologists advocates for testing when a person's on hormone replacement therapy, testing every 6 months. If I change the dose more than 10%, I should test within 1 month. That's what they advocate for. So every woman that's on hormone replacement therapy, you should be getting tested every 6 months. That's the standard that's established by them. It's not followed because that goes against what insurance companies would prefer to pay for. And so, as a business model, they let you come back once a year. I am not a fan of this. Your mood, your memory, your brain chemistry also is intimately linked to progesterone. And so, it's hard not to have anxiety when you don't have progesterone. It's hard not to have depression and insomnia without progesterone. Now, some women can go through life with no progesterone and don't have these symptoms. There are redundancies in their mind, and God bless them. I'm happy. I want that for them. Whatever they're at peace with, we're good with. But with you with these symptoms, this, until proven otherwise, is progesterone. And how we prove for that, we give you progesterone, we look at your lab work, we verify that it got to a clinically significant level, and then when I sit down with you, it's like, did it help? How's your mood? How's your anxiety? How's your sleep? We measure you on a scale. What's the body fat percentage? Is it going down? Is it going up? What are we doing with this? So long as I'm monitoring these things, I'm doing my best work. I hope that helps for your next appointment. I truly do. And I do want you to know you deserve a doctor to see you twice a year. We're not, there's no reason for us not to be available to you twice a year. There's no reason for us not to run basic lab work with you twice a year. This is something you're entitled to, in my opinion. I hope that helped. So this one is an important one, and if you look at my if you look at my earlier years doing this podcast, you'll find I did a bunch on topical estrogen, and I was not very kind to it. And let me tell you why. Topical estrogen, it is given to women without any explanation as to the possible consequences to their spouse and to their children and to their pets. And the reason why it's used so commonly is because it's very inexpensive. And it just is an easy thing to just give you a topical cream, you're on your way. And I want you to know, if that worked well and it was safe, I would do it all the time because that's awesome. I mean, how many people don't moisturize You know what I mean? We all moisturize at some point in our lives. You know, even guys start moisturizing at some point, right? So moisturizing. So topical is not a bad thing in that sense. It's just the research is really clear on its ability to transfer. So I know that triggers people. Again, in the earlier years doing this, I'm so protective and defensive of my patients and their health. I become very it's part of being a doctor. You know, you're like, these are my people. I care about them, and I don't want my patients taking a topical unless they have to. And if they do, then I'm going to sit down with them and go over how to do it in the safest way possible. And if you're one of my patients that we had to do topical, you can attest to me doing that. I'm like, wear gloves, do it this time of day, don't spread it, make sure you take a shower afterwards. Like, I'm that diligent. So there's a couple questions about the topical estrogen that I want to explain, but before I do, I want to give you a little bit of a quick primer. Estradiol in a cream is a pure hormone, and they just mix it with the cream, and then they give it to a pump. Fine. If you take that estradiol pump and you pump a few pumps out, and you put it up on this little piece here of my microphone, and we leave this room, and we come back in a year, there's still estradiol on this. It doesn't go anywhere. Estradiol does not evaporate. Estradiol does not aromatize in air. Estrogen does not get absorbed into metal. Estrogen just stays here. It will just stay here. It's a very, very stable compound. It's just here. So when you put it on your skin, it's going to stay there. Your skin is not meant to absorb medication. That's not its design. That's what it was originally designed for. We're using it to absorb medication because it can, not because it's made to do it. I know that whenever I give you a medication, I, as a physician, need to be educated on pharmacodynamics and pharmacokinetics. That means how it gets into your body, and then once it's in there, what it does. I have to know it inside out, backwards and forwards. And you deserve me to do that. And every doctor that has a license to practice medicine had to learn this too. But some people, we take a test, we learn something, and then we forget it right afterwards. This is not one of the ones we should be forgetting. So if I put estrogen on your skin, you'll absorb a fair amount of it, absolutely. And I'll run the test to make sure you absorbed it because I care about you. And I want to make sure my dose is not too high and also not too low. And it's you. You're my patient. I care about you. But I also care about your pets. I care about your dogs, your cats, your parrot. This is a woman who commented about her parrot. I care. And your spouse. I do. Someone commented that men need estrogen. You're right. We do need estrogen. It's true. Some of us probably need more than others. Because it is important. Anyway, the studies are clear. It'll be cited below in this episode. When women apply estradiol transvaginally and they have intercourse with their husband within 24 hours, the husband will be exposed to estradiol. His penis will have estrogen on it. And the woman's absorption of estrogen will be diminished. I think it was 60% or somewhere in the neighborhood. They diminished. So you're not going to absorb as much because during intercourse, he's going to be getting it on him. And so he'll be removing some from you and you'll have less yourself. So that's clear on the literature. There is enough studies. You can just Google this yourself about transfer of these hormones. This does happen. So the comments I want to really speak to clearly. Rosie, you know, she comments, can you talk about what actually happens if it does transfer to your partner, please? It's if you're transferring it to your significant other and it was a transvaginal route, it's going to be on his penis. This will cause issues with him. This is the last place you want to put estrogen on a guy is his penis. It really is not good for it. I mean, again, we as men need estrogen, and estrogen is an important part of us. Even we need estrogen to actually have an erection, which is good, but too much is not good. But also ethically, he never consented to this. We want to be better than what's been done to you. We want to be better. There's so little consent was done with you. And those of you who put topical on who are not told or educated on what it does, they did not get consent from you, true consent, true informed consent when they gave you this medication. You deserve that. We want to be better. So one, we want you to understand that when you apply this topical estradiol, you need to make sure you do it in a way that you put it on, you get the absorption, and then you wash it off. No remnant. You want to make sure that when you apply it, you're careful with who else you may be in contact with any of the materials you had around you. So if you have towels or whatever around you, anything that could have that estrogen on it, you want to make sure it does not get on those people around you. No one consented to being on their body. So that's right here in my heart. It's very important to me. Um, there's another comment in here. Um, this is DSWELL52, DSE well 52. So how about vaginal estradiol? I was told safe sex after 12 hours. Even then, I'd be cautious. Uh, it's important to evaluate your partner if you're doing transvaginal and you're having intimacy, 12 hours later. It is worth running an estradiol panel on him and on yourself to make sure that you didn't lose any to him and that his is not too high. That is a good thing to evaluate for and prove for X, because it's your this is the person you're intimate with. This is your spouse. This is a very personal act you have with him, and there's so much trust that goes into that intimacy. And he is trusting himself to you, and you're trusting your body with him. It's a big thing, and I think this is unfair that it is given to you without really clear education onto how to do it correctly, and also for the physician saying, this is what I want to do to prove that it's safe, because that's what this is. We want it to be safe. Then the final one I want to answer here was Mandaq, MANDAAQ_Q. I love you guys. I love you guys' handles. I love your handles. You guys are my favorite. I didn't know what I was missing in my life until I met all of you. This podcast has been my favorite. Um, it's been such a huge, beautiful thing in my life. I love, again, my favorite things is watching you be supportive of each other in the comments. That just moves my heart so much. I just love to be a part of something that is helpful. I just do. I did not know what I was missing in my life till I met you guys. Thank you. So, and your names too are great. So, Manda_Q. What are the best locations to avoid transfer? Uh, behind you want to be on thin areas of tissue. So, under the elbows, in the antecubital crease, or behind the knee. These are good places for absorption, for good, heavy, healthy absorption. If you put it onto these areas and then you put on, say you're wearing you're wearing a dress or a skirt, you put it behind your knees, and it's long enough so it doesn't. So if you're sitting down, you don't want the back of your knees to touch a chair, so wick into the chair, not good. So you want to make sure you're aware of that. But if you put it behind the knees and you have a little bit of a longer dress or a longer skirt, that's a good way of doing it. Under the elbows with a long sleeve blouse, that should be good. But you want to be cautious. And the thing I always advocate for is apply it, wait, take a shower. Let me run the labs after a month of doing that. That routine is safe as long as you wash it off your body after a period of time. Some people it's an hour, some people it's longer. But it's one of those things we have to find individuals. I don't typically write topical estrogen anymore because of this. I do injectable. Very common for me now to use injectable cypionate to estradiol cypionate. Patch, holy smokes, the patch is the best actually. So if you can't do the injectable, you don't want to do a needle. I get it. No one likes needles. But say you want to do a topical, the patch is really good. The patch is really good. So that way it's all self-contained. Then you remove the patch when you're done. And the patch is bioidentical. It is bioidentical and it is safe and you will not transfer it. I'm a huge fan of it. So if you can't do the injection, then we do the patch. And then if worst case scenario, we do the cream, and we have to be so careful about that with its spread, lab work, and clear communication, healthy communication, and consent. So I hope this helps answer some of your questions. Our next series, I'm starting to put together. I have a few ideas on it. I'll try and post a little bit more about that before we put it out there. But again, thank you so much for your comments, your questions. I do appreciate your participation, and I appreciate your guidance. It does guide me. So thank you, and I will see you at the next episode.